I appreciate your being here this afternoon. Surprise billing is kind of a tortuous subject for all the laughter, after all the laughter we've had and after that great lunch. So please, I am one of those speakers that if you have a question or a comment or anything at all, speak up. The one thing that I know about talking about the topics that I generally address, they are not all that exciting. So I was sitting in my chair listening to our lunchtime speaker thinking, how can I make this fun? So I'm going to engage you to help me as we go along. A lot of dry information. It is truly important, I do think, which is the other part that I want to get across. But as I mentioned, it helps me if you interrupt with a question or a comment. And if you disagree, please speak up, because that helps me most of all. All of you have individual experiences with what I'm going to talk about, so that will be very interesting. So shall we get started? Thank you, thank you. Some of this you have probably already seen, but I wanted to give us a little background to start on. And then we are going to talk about this afternoon the newest guidance that was published back on September 30. So we will get to some new information. I just thought I needed to repeat a little bit of what we're talking about, just in case no one has become involved with surprise billing just yet. So, as you see there, after several years of disagreement, Congress passed the revised out-of-network billing requirements within that very last regulatory session of the Congress in 2020. And I have to admit to you that to begin with, I thought the legislation was going to allow us providers a little more reimbursement for some of these services, just because I think, as we will talk about, Medicaid and Medicare reimbursement rates have been left out. So I'm thinking, oh, commercial or private coverage rates probably will give us more reimbursement than if we had included those two government payers. And we'll talk about that as we go along. The legislation was considered to be a compromise that does meet both provider and patient needs. Now, think about a patient's, and we're going to talk about them, of course, a little bit more, but understanding from their perspective what out-of-network payments have been in the past. The law, as I mentioned, may represent improved payment opportunities. We'll talk about that. All of these initial regulations were contained within that H.R. 133, which the Omnibus Appropriations and Emergency Coronavirus Relief Act, just so if you do want to, within your particular job role, if you want to read the actual initial publication of guidance, I think sometimes that's good. I could say if you want to go to sleep at night, please pull it up and look at it. But at the same time, I think each of us sees the legislation a little bit differently depending on which area of the rev cycle we may be working in. The legislation does apply to, the important information on this particular slide is that it does apply to ERISA coverage plans, and you'll see why that one is important. And I've got some updated information on this particular slide, but I want to point out that the law does contain provisions to protect. The law actually says consumers, but I always put patients right there because that's who we're talking about, against the cost of surprise medical bills, particularly emergency care provided by out-of-network providers or facilities. Providers, meaning physicians and or other licensed providers, and hospitals and other areas that may provide emergency care, including emergency air transport. It also covers non-emergency services provided by an out-of-network physician within an in-network facility for which patients do not consent. I will mention here, we have about or I should say I have about 6 or 8 slides on that consent process. So if you don't have my presentation back from June, please just email me and I'll send you that initial presentation, because I'm not going to talk about consent a lot today, but you will want to be aware and understand what those requirements are. Okay, on this next slide, we have a little bit of updated information. Going back to 2010 and 2015, about 39% of ER department visits to in-network hospitals resulted in an out-of-network bill. That was updated for 2016 to be almost 43%. And that percentage did surprise me just a little bit. And of course, many of us within our facilities have contracted ER physicians, or even in our smaller facilities, I'm seeing contracted mid-levels, PAs and NPs. So certainly there may be an out-of-network physician or provider working within our particular facility, and we are in-network for the patient, but the physician or the other provider is out-of-network. And as you can see there, the average amount of a surprise medical bill has increased up to about $628. And I do think that's a considerable amount. We have had information for a number of years that simply says even a $250 surprise medical bill cannot be easily paid by most of our patients. So certainly that part gets my attention. The other information on this slide that I do think is very attention-grabbing, so to speak, is that very first bullet point, payments made to providers by patients who did receive a surprise bill for emergency care. Payments now were more than 10 times higher than those made by other individuals who had insurance coverage for the same care. Okay. Out-of-network cost sharing in the past has not counted toward a patient's deductible and maximum out-of-pocket. Of course, that's changing. And as you see there, about 40% of Americans report they struggle even to find $400 to pay for an unexpected medical bill. I know that if you look at your self-pay or even self-pay after insurance, you will find that that is absolutely true. Some of the most difficult amounts for us to collect are our self-pay balances. Okay, now this slide I think gives us all of the basics of this particular legislation. Patient cost, as I mentioned, will be limited to cost sharing, amounts that apply to in-network services, and the amount patients pay will meet their in-network annual deductible. That one sentence there raises my attention regarding registration of patients and understanding, even if they are out of network, how are we going to determine their particular patient balance that is owed, and a new tracking mechanism for out-of-network patients so that we understand what their cost share percentage should be. The regulation does require out-of-network service providers to give patients 72-hour notice of their estimated charges. Now, does 72 hours sound like a long time to you? It doesn't to me, okay? When you think about if I'm scheduling, let's say, a surgery on Monday, and I've got just 72 hours in order to be sure that I've communicated, I've determined eligibility, I've looked at what will this particular patient owe for his or her patient responsibility, and actually, given that information to the patient and obtained a waiver if my physician happens to be out of network. So lots of considerations just even at the beginning of understanding what this legislation means to us. Patients must agree to receive out-of-network care for the hospital or physician to bill and expect payment of full charges. Now, What do we call those full charges? It's always interesting to me that in healthcare we have several different names for the same information. We generally refer to that as balance billing. In other words, if my particular patient is out of network and there is no payment on our particular account for the services provided, we generally expect what? That patient to pay what? 100% of what our charges may be. Is there any other insurance company or coverage plan that we would expect to pay 100%? Not that I know of. Now, if you all have one, speak up, but I don't know of one. So simply understanding, I'm back to, yes, we can talk about the legislation, but how are we going to put that particular requirement into actual or realistic work procedures, I think is what we should be thinking about. The legislation does rely on voluntary negotiations between insurers and providers, backed up by independent dispute resolution, and we call that arbitration, if negotiations fail between the insurance coverage plan and the provider. And we've got lots of information on that particular independent resolution process. If you all will excuse me 1 second, I'm going to try a sip of water. As we talked about to begin with, the small win for providers relates to the legislation did omit Medicare and Medicaid reimbursement rates during that arbitration process. And of course, we're going to talk some more about that. These government payers are often far lower than the negotiated rates paid by insurers and other self-insured employers. And we're going to see how that works. Questions so far? Okay. Some more details. If the health plan does cover emergency care, all services must be covered without prior authorization. Now, I particularly like that requirement because for years and years and years, insurers or coverage plans could not require an authorization for emergency care. Then all of a sudden, in the last 3 to 5 years, I think we are seeing more emergency-related services requiring either a pre-authorization or simply an authorization after the fact, what we call a retro authorization. All covered without facility participation in the health plan. Again, that one gets my attention because now, even if my facility is out of network with that particular plan, I'm still going to fall under the particular requirements for these services for that patient who is out of network. Services must cost the patient the same as in-network care. Patient cost sharing will count toward the in-network deductible and out-of-pocket maximum amounts for that particular patient, keeping in mind new tracking, new calculations for us as far as what that particular patient is going to owe. The out-of-network provider must bill the health plan directly. The health plan then has 30 days from bill date to pay or to deny. If paid by the plan, payment must go to the provider of the services. And again, that's a requirement that I do like. Instead of the payment being sent directly to the patient, it is going to be sent to the provider that was responsible for the care. Next slide. The legislation establishes the following payment parameters. The patient's cost sharing is calculated from the previously determined recognized amount. Now, this slide we do have a little bit of updated information for, so I want to drop down to where you see that July 1. The lesser amount of either the bill charges or the qualifying payment amount, which is generally the insurance plan's median contracted rate. And we will see that in this later legislation on September 30, that median contracted rate becomes even more important. So we kind of want to zero in on that and understand what it means. The regulation, as mentioned, defined the qualified payment amount. The dollar amount will be based on historic rates between the health plan and the provider, or it will be based on the median contract rate, as we mentioned, recognized by the health plan back on January 1, 2019. And that date still stands, even though we do have updated guidance or updated regulations. Just keep in mind that when we are talking about the median contracted rate for that particular insurance plan, we would go back to January 31, 2019. And I'm hoping that may be updated. This law does go into effect, as you know, January 1, 2022. So we've got what? Remainder of October, November, and December to be prepared for what we will need to do. The number one question I get every day is what? Okay, Linda, isn't this going to be postponed or at least, delayed until we are more able to address patient needs for COVID-19 or all of the information that is just up in the air right now regarding reimbursement? I look every morning to see, is there any information about surprise billing being delayed? I have not seen that as yet. I've looked at CMS, I've looked at the federal government, the OIG work sites. So I guess I stand before you today saying, as far as I know, as far as we know right now, it will go into effect January 1, 2022. And I need to go back to the median contract rate within the same market and then increased by the Consumer Price Index year over year. And we'll come back to that just a little bit later. Arbitration, to begin with, I thought arbitration was going to be a very beneficial process for us providers. Now, in our latest guidance, we'll see how that has changed just a little bit. But I do want you to understand the arbitration process. We call it independent dispute resolution, but as you will see, it is simply a process between the insurance plan and the provider to come to a payment amount that both can agree on. Instructions are provided to the arbitrator to consider the median in-network rate paid by the insurer. Now, that one causes all kinds of question marks in my head. Why? If we are not contracted with that particular insurance plan or payer at all, I don't know how we will know what the median contracted rate actually is for our location for those services. So I'm hoping, again, that we get additional guidance before the end of the year where our insurance plans or the actual payers themselves will have to share with us what their median contracted rates are beginning on January 1. And I don't like this particular provision. The federal government is saying to the arbitration entity, do not consider the provider's higher billed charges. And that one bothers me a little bit just because what do we generally base our charges on? I'm a little bit naive about the subject, but charges are supposed to be based on cost, right? Certainly with some markup there. But if you think about cost or expense for particular healthcare services, in all of my years, I've never seen cost actually go down. Now, sometimes the one example that's presented to me is a generic drug may come out that takes the place of a very name brand or specific pharmacy item. But as far as our providing patient care services, whether that's inpatient or outpatient, we generally see rising costs. Equipment costs more. Certainly, our team members, both clinical and non-clinical, cost more. So I just think I would have preferred not to have this said to the arbitration entity for, oh, don't consider that provider's higher billed charges. I do think at times we do overcharge. Again, I probably have a more prejudicial look at it, but even if we're overcharging slightly, it's generally because we know that we have a particular payer who is paying less than it cost us to provide that service. So we're trying to equal out or balance out reimbursement. The losing party must pay the cost of arbitration. And see, I think that's almost a detriment, or that's saying to us as a provider, or even saying to the insurance plan, if you are not confident in the amount that you're requesting as payment as a provider, or that you are suggesting as payment if you are the insurance coverage plan, then you may end up having to pay the entire cost of this arbitration process, which I think kind of, I don't know that it will, but I have the feeling that that probably will deter some of our smaller hospitals from getting involved in arbitration. What do y'all think? Y'all are very quiet. Yep. Okay. So here we are on July 1 again, and we've had two. I know you've heard a lot of talk about, we had the surprise billing legislation back in December. We had a July 1, which was called Part 1 of an interim rule, and now on September 30, we also had published Part 2 that we're going to get to in just a second. As I mentioned, a provider that receives an initial payment or even a denial from a health plan for out-of-network care may either accept the payment or open negotiations for arbitration. And there are a lot of dates in here, so about 3 slides in the future, I put all the dates in just a little chart, so I'm hoping that will make it easier for you. If negotiations fail, either party may request that independent dispute resolution entity during the 4 days after the initial 30-day negotiation period. Now, and I'm not here to say bad things about any of you or any of the hospitals that I've worked with over the past, 26 years or so. We don't do anything well within 4 days. What do y'all think? So this gets my attention that we're going to have to be very prompt with our understanding of what the law requires, and then we're going to have a review or an evaluation process very quickly, because if we do want to open arbitration, we have that 4 days in time to do that. That's called the notification to the entity, to the IDR or arbitration entity, that yes, we do want to go through arbitration. The parties then have 3 days to jointly choose that particular IDR company or entity. If they can't agree, then the secretary has said he or she will step in and choose a particular IDR entity. The provider and the health plan may continue negotiating during this process, and if an agreement is reached between the parties during negotiation, then they would split the IDR fees. We can batch together disputed claims that occur during a 30-day period. HHS will develop a process to certify IDR entities. We do have a good portion of that now, coming from the September 30 Part 2 interim rule. And as you see there, IDR entities must have relevant medical and legal expertise, have the ability to make timely determinations, and they cannot be biased. In other words, they cannot be a health plan, a provider or association of providers, or health plans. Once they are certified to be an arbitration or an IDR entity, that certification will last for 5 years. More days now, 10 days after that certified IDR entity is selected, the provider and the health plan must submit their best payment offer with supporting documentation. I've been looking for what is going to be supporting documentation, and we've got just a little bit of information, but not as much as I would like to see. So we'll talk about that one a little more as well. The IDR, or arbitration entity, will select one of the offers after taking into consideration a number of factors outlined in this particular Surprise Billing Act: geographic region, market share, training and experience of the provider, and of course, patient acuity. And see, that brings up to me, our supporting documentation is going to need detailed data from the medical record about our provider that carried out the particular service, certainly some understanding of why was this particular procedure or medical service chosen over some other service that may have been less expensive. So see, my mind kind of goes all over the place with that particular requirement. The IDR, as I've already said, shall not consider usual and customary charges or rates paid by public programs. The losing party is responsible for all fees associated with that arbitration process. So to the next slide. Once a resolution is determined, the payer has 30 days to provide the agreed reimbursement to the provider. And I personally think that's too long. I know several comments have been sent, particularly to CMS, saying, once the decision is made, why is it going to take 30 days for that particular payer or insurance plan to then remit payment? So again, that's what I'm hoping to see will be updated or changed just a little bit, but that's the regulation as we have it now. The IDR entity's decision is binding and not subject to judicial review. I kind of like that one because we're saying, you know, if the arbitration entity decides more on the behalf of the provider, then the insurance or the payer can't bring suit not to pay that amount, so to speak. So I'm hoping that will speed the payment process along just a little bit. And those other two have been updated a little bit, so let's go to the next slide. And here is my chart to give you all of these time requirements. Certainly, I think as we begin this January 1, as we go into providing services and charging and billing our patients under these requirements, you will want to have at hand, if I do decide on arbitration, here is the timeline, or here are the date requirements that will need to be followed. And I won't go over those with you again. I just hope that you can find this slide and the next slide are all the dates that's required for the process. I hope that you will find those beneficial. Okay, so here we are for September 30. This is all new information. It is called Part 2, which is the Independent Dispute Resolution or Arbitration Process. And then notice that it is also called the QPA Summary, Qualified Payment Amount Summary. When making a payment determination, the Certified Independent Dispute Resolution entity must begin with the presumption that that QPA, which is the median contracted rate for the particular service location, is the appropriate out-of-network amount. And here is where I see, now you all disagree if you like, but here is where I see now the legislation has kind of gone over to the insurance plans side and said, we're going to start out with not considering your charges, but simply looking at what would the median contracted rate be. And I want us to know that amount as we begin working with the patient checking his or her eligibility to see this is a patient that is out of network, but let's understand, based on what we know about an insurer or payer, what are we going to be paid for the services that we are providing? And I know, I've never been in a hospital that said, oh, Linda, wait a second, let's see what this plan is going to pay. We generally are not concerned about that. But I think because the regulation requires our communicating with the patient, as you'll see in just a moment, and our being prepared for understanding what that patient cost sharing is going to be, this is kind of an upfront process that we will need to put in place to be able to meet the regulation or meet the requirements of this particular surprise billing legislation. If a party, now this is straight out of the law itself, if a party submits additional information that is allowed under the statute, then the certified IDR entity must consider this information. If it is credible, okay, that's where my little question mark appears in my head. It does not define credible, so is it credible to the insurance plan, or is it credible to the provider? And of course, the arbitration entity or the IDR is going to decide that, but I want to know, how do we prove credibility for a higher payment, which is what is important to me. And as you know, I should have admitted right to begin with, I am a reimbursement person. Don't want to do a thing that we're not supposed to do for what I now call optimum reimbursement, not maximum. I don't want to go there, but I want to understand for every payer, for every patient, what do we need to do, both from the clinical perspective and then from the financial or rev cycle perspective, what do we need to carry out to be assured that we can collect for the services that have been provided to this patient? For the IDR entity to deviate from the offer closest to that qualified payment amount, any information submitted must clearly demonstrate the value of the item or service is materially different from the qualified payment amount or that median contracted rate. So again, I think the burden is being placed on the provider to prove, yes, I understand what your qualified payment amount would be in this circumstance, but because of this particular patient's comorbidities or perhaps a complication that happened during the procedure, all of these different medical occurrences that we know can take place, we're back to now understanding from our documentation and from the information clearly available on a particular patient, can we make that credible case for a higher reimbursement? And can we even make sure the information is being reviewed, which is going to take additional preparation on our part to get that information to the arbitration entity. Without this additional information, the certified IDR entity must select the offer closest to the plan's median contracted rate. So I see the surprise on your face, which is absolutely true. Are we going to want to go through arbitration? What do y'all think? Okay, now you have to talk a little bit. Yes. According to the law, and y'all remember, I'm not an attorney, just doing the best I can with all this information. According to the law, as long as you, in your documentation, your supporting documentation, make a sufficient or credible case that yes, this particular patient is out of the norm or routine for some reason, then it should be paid at a higher rate. Do I have confidence that that's going to happen? I do not. How much luck did we have with the RACs, with the recovery audit contractors? A little bit, you know, I know many of you did, but simply understanding why in December we had legislation that clearly wanted to be able to provide a small increase in reimbursement for providers, and now the following September we are back to hospital or provider, you're pretty much going to get the median contracted rate for that particular provider. Anybody want to disagree if you see this differently? And it'll help us, I promise, if you want to speak up. Anything at all? Y'all are never this quiet. It was all that good lunch, I know.
I have a question. Maybe you're about to get to this, but do we know when insurers are supposed to publish this median?
In all honesty, I don't know that it even is going to be published. I don't see how the federal government, which is a ridiculous statement for me to stand up here and make, can expect us to accept that median contracted rate if it's not published. But I don't know. I've not been able to find any conversation about when that will come out or how it will be shared with us, any of that information. Yes, ma'am. I have not, but that has been my conclusion. I've not seen that language, but I think that certainly will be the case, keeping in mind I can look at the patient's medical condition, I can state my reasons why I think it should be higher, but again, we're back to having some true definitions of what does credible mean. What is materially different one patient to the next. I think even with our standardization in electronic medical records, unless we can come to some templates that specifically ask clinical questions in order to be able to differentiate between patients. And I have been working with a hospital lately. We're going back and looking at any patient who the physician documents a complication. How well does our EMR actually document that particular complication for that patient? We have always said, if I have a complication and it's an inpatient, it should do what? Increase my DRG. So I think perhaps with this legislation, we're going to have to look at, is it a routine, and what in the world is routine, patient who received this procedure, or was there some difference, materially different, that I can be sure is documented so that I can request that additional payment? Okay? Let's see. Let's move on. Requirements for providers and facilities. Now, I'm kind of moving on from median contracted rate, but everybody got the message, right, that generally is being identified as what we will be paid as a provider. And this was brand new information in that September 30 Part 2 interim rule. Requirements for providers and facilities. During scheduling or request by a patient, this regulation requires inquiry about the individual's insurance status or whether or not an individual is seeking to have a claim submitted to their health insurance coverage for the care they are seeking. Now, remember HIPAA. I don't know what year, maybe about 1996. HIPAA said, even if I am a patient with insurance coverage, what can I do? I can opt out. I can opt not to use that particular insurance coverage if for whatever reason I want to. At the time, it was primarily for if I work for an employer who provides a self-funded employee insurance coverage plan. Perhaps I have a diagnosis that I don't want my employer particularly to know about. So HIPAA said, as I mentioned, even if a patient has insurance coverage, he or she can opt not to file that insurance coverage. So now surprise billing is saying to us, if you have one of those patients, or if you have a patient that does not have insurance coverage, the provider or facility must provide a good faith estimate of expected charges for items and services to an uninsured or to a self-pay patient that does not have health care benefits under a plan, has health insurance benefits, but does not plan to have a claim submitted to their coverage plan. Now, I know that we, hospitals in particularly, have come a long way towards providing price estimates, or what should I call those? Patient responsibility estimates. But how good are we at it? You all tell me what you think. Good? Medium. And that's probably what I would say. Certainly there are some routine procedures. If I ask you about a colonoscopy, with no particular problems, or all those CPT codes that we can add on to a colonoscopy, we probably can come pretty close. But if I ask you about a cardiac procedure that we don't truly have a diagnosis yet of what the problem may be, I saw an estimate the other day that was a patient portion of $1,400, and it ended up to be exactly twice as much, $2,800. Now, this particular legislation is saying to us, in my next slide, I hope, the good faith estimate must include expected charges for the items or services that are reasonably expected to be provided together with the primary item or service, including items or services that may be provided by other providers and facilities. Now, what does that mean in my understanding? That means that if we are having a particular, let me go back to my cardiac diagnostic procedure in my cardiac cath lab, I need to estimate both the facility, which sometimes we call the technical component, and the professional component. Both of those, because they are joined together in what this particular patient may owe, would need to be provided in that good faith estimate. What do y'all say about that? Pardon? With price transparency, and I'm sure you're right to some degree, but I think about price transparency, we have to make those charges available, but I don't know that we are being held to a specific, how close are you to the estimate that you're giving a particular patient. I'll go on. If an item or service is something that isn't scheduled separately from the surgery itself, it will generally be included in the good faith estimate. Other items or services related to the surgery that might be scheduled separately, like a pre-surgery appointment or physical therapy in the weeks after a surgery, won't be included. So we have a little bit of information of what should be there. And I know for employed physicians, we may have the capability for determining what that professional component is going to cost the patient. I think it's going to be a little more difficult for those physicians within our facility that are credentialed but not employed by the hospital.
So for your surgery, are you saying that the surgery also has to include, you live in anesthesia and you're over the surgery, would the surgeon fall into that same category?
Yes, as far as I know. And anesthesia. Now, don't throw any pie at me right now or anything. Again, we still have the remainder of October, November, and December, and because there has been such an uproar about a little bit of this as far as out-of-network and self-pay patients, I think that we will see some clarification on these particular requirements, and I do have a little bit of good news on this slide. But yes, when we are scheduling that patient for surgery, my understanding, reading this regulation the way it was written for September 30, then we need facility or technical charges, we need anesthesiology, we need a surgeon or cardiologist, we need any implant that may be used if we're talking about cardiology. So lots of information going into our good faith estimate. This is the little bit of good news. Health and Human Services understand that it may take time for providers and facilities to develop systems and processes for providing and receiving the required information from others. Therefore, for these good faith estimates provided to the uninsured or to a self-pay patient from January 1, 2022 through December 31, 2022, HHS will exercise its enforcement discretion in situations where a good faith estimate provided to an uninsured or self-pay individual does not include expected charges from other providers and facilities that are involved. So we kind of have a year's grace period for those other services, but I would encourage you to begin working on it now, because I think all that it will take is several patients complaining about, we were supposed to get a good faith estimate, but hospital ABC didn't tell me about all these additional charges, and we will see additional legislation, of course. So everybody heard, we have a year that HHS is saying they will, from the way I read that, they will look at individual cases if a patient does complain, but they are giving us some time to work into having that surgeon, anesthesiologist, all of the additional charges. Okay, when an uninsured or self-pay, I wonder what time I'm supposed to finish. When an uninsured or self-pay patient receives a good faith estimate and then is billed for an amount substantially in excess, HHS established a patient-provider dispute resolution process to determine an appropriate amount. I will have to admit to you that I don't ever think I have, in all my years, seen one piece of legislation, which of course now we've had 3, but this is reaching into a number of different areas within our particular provision of care. So there's more, there's more to it than just sitting down in an afternoon and saying, oh, here's what we need to do. Even as complicated as billing is right now, I think most of the billing guidelines we get, we can say, oh, this affects charge capture, or this affects, how we're going to expect reimbursement for a particular service. But just thinking about all the different areas within the revenue cycle that are going to be affected by this surprise billing legislation, I'm encouraging you to begin preparation right now. Let's see. We do have this eligibility dispute resolution process and a definition of substantially in excess. I want to go all the way down to the bottom bullet, and what does it say? HHS has defined substantially in excess as the bill charges being at least $400 more than the good faith estimate for any provider or facility listed on that good faith estimate. $400 to me sounds like $5. It is just such a minimum amount for it not to meet the requirements of a good faith estimate. What do y'all think? Okay, I promise I'm almost at the end. To learn more about the administrative fee, which is just $50, and the allowable independent dispute resolution entity fee, I have the website there so that you can go out and see calendar year 2022 fee guidance for this federal independent dispute resolution process. I didn't say that correctly. Resolution process under the No Surprises Act. I do encourage you to go out and look at that. I didn't try to summarize it for you because a lot of it depends on size of the facility, or even the provider with whom you are working. So I just put it here so you can go out and find it, and you will want to review that. I'm suggesting that. July 1 has come and gone. We did get part 1 to the interim rule. December of this year, we should get the final instead of the interim. And of course, as I mentioned to you several times, we're looking for clarification to be able to understand how we're going to put into practice many of these things. I will say again, as far as we know, the resolution, the law, will go into effect January 1 of this coming year. If anyone does not have that initial presentation that I did on surprise billing, I'll be glad to send it to you. Here are all the laws that I have been referencing, or regulations I probably should call them, if you want to go back. And like I said, sometimes I think it's good for each of us to read the information just so that we understand for our particular our role. Where are we in the rev cycle, and how is this going to affect us? You see there L. Corley at extendhealthcare.net. I welcome your questions, your comments. It's always good for me to hear what you're asking about, hear what you're thinking. I will do my very best to research and provide an answer to you just as quickly as I can. Questions as we end this afternoon? What do y'all think? Yes?
This patient estimate piece that we just talked about, is there any indication in this that a predetermined single case agreement would preempt this?
No, ma'am. As far as I can read, and I've heard other, I'm not an attorney, but I don't think that there's going to be, if it's out of network, a predetermined rate, from what I understand, will not be in effect. Now, the minute I say that, what are you going to say? Oh, but we have so-and-so agreement. So I would encourage you to go to your healthcare attorney and see what he or she tells you. Yes, sir, in the back. Question? Okay. Thank you all. It's a lot of information. I appreciate being here with you today, and just let me know if I can help you. Thank you.